welcome everybody. We decided to run this webinar because we did a session at Future Scott, and we presented more or less the slides that you'll be seeing today. There were quite a few people who couldn't make that session and asked if we could share slides. Because there were quite a few people, we decided that we would run another webinar to give other people who couldn't attend the Future Scott event the opportunity to actually see the slides and give the opportunity to ask questions. So I'll give you, before I introduce the speakers, I'll just give you a little bit of background. So we're Insource, we're a data management company, and we've been working with the NHS for 30 years. We've been in data management, working with the NHS for over 20 years now. One of our customers was NHS Highland, and they had our some of our solutions, a number of them. One of them was our pathway management solution, which helped to manage pathways, but it wasn't being used for managing cancer pathways. So NHS Highland came to us. We work in partnership with our customers, and they said, could we help them, support them to actually be able to manage their cancer patients in a better way. So working with them over a number of, I think it actually took about 2 years to develop the product. We developed our cancer pathway management solution called PP Plus Cancer Pathway Management Solution. And then after they'd been using it for a while, we were speaking to some of the other health boards, and Glasgow decided, Greater Glasgow and Clyde decided that they would like to take up the solution as well. So we started working with Greater Glasgow and Clyde, and the product has been developed further. It's got more functionality now. It's moved quite a long way from the initial development that we did with Highland. And so today you're going to hear about the difference that the solution has made in Glasgow. They've gone live with the solution now. So we've got some report of how the solution was implemented, the difference it has made in just the few weeks that it's been live, the difference that it has made as well. So I would like to introduce you first of all to our speakers. So first of all, we have Donna Smith, and they will introduce themselves as we're going through the presentation. So we've got Donna Smith, who now works for Insource. Donna's going to tell you how she's been working with the NHS for 30 plus years, but moved over to Insource. We've got Dennis Betts from NHS Greater Glasgow and Clyde, and Charlotte Hilliard as well, and they will both introduce themselves as we're moving along. And I've just got a couple of people messaging saying that they either can't hear or that they're struggling to see. Can everybody else see the presentation, and can everybody else hear? Okay. If you have any questions during the presentation, could you please put them in the chat? Thank you very much for everybody responding. At least a lot of people can hear and see. If you have any questions, if you could put them in the chat, I will be collating all of the questions, and then towards the end of the presentation there'll be plenty of time to actually be able to respond to some of your questions. So because of the numbers, we've got quite a lot of people in the webinar today. We have turned your cameras off and we have turned your microphones off. So hopefully if you've got any questions, please put them in the chat. Okay, so Donna, would you like to make a start?
Thank you very much, Nadine. So as Nadine said, I've worked in the National Health Service for 34 years in both operational and strategic roles, and have been a client of Insource's for over 15 years prior to joining them at the beginning of April. The NHS, as we all know, has lots of data, but the big challenge for us all is in how do we access that data to allow it to be used to support patient pathway management and support the meaningful transformation of services. Laterally in NHS Highland, I managed the analytical teams, and I watched them spend significant time producing operational and board reports, and significant time trying to work through with our operational teams the exact requirements that they were looking for. And it was very clear to me that we then needed some sort of data strategy. We didn't know how many systems were being used across the National Health Service, and systems were being developed by individual departments. People were using Excel spreadsheets, and a plethora of reports were being maintained manually. And it really became very clear to me that that was a non-sustainable solution. And one of the big issues, as we're all trying to do, is reduce our access times. And during COVID, our access times for elective care and cancer care have just gone in the wrong direction. So, as we all know, the Scottish Government has set us specific targets, and we seem to be failing to meet those targets. And that's not through the want of everyone working harder and longer and more productively. We just don't have an efficient way of understanding where we put our best efforts. And how do we use our data to manage those best efforts so that we improve our access times for patients? And we all know that we have to do something different. The longer patients are on our waiting list, the more comorbidities they have, and the sicker that they become, and the less likely they are to have the most optimum outcome. And the system feels it is very overwhelming at the moment, and there's a limit to our workforce capabilities. We were listening to our Chief Executive of NHS Highland yesterday at the Innovation event, talking about workforce being one of her top 3 challenges. And we know we can't just knit our doctors and nurses to become available tomorrow. And we also know with the capital situation in Scotland, we can't just build new hospitals. So could having access to accurate data really make a difference for us? And I truly believe it can. In Scotland, we're very fortunate to have the position that we have very many agreed national clinical pathways that are known and understood. But we also know that we live in the real world where patients have slight deviations and variations from that pathway. And I have heard many a clinician tell me, once they understand the administrative processes that we adopt to manage those patients through the pathway, that it's a miracle that patients make it. And we all know that the biggest risk administratively is losing a patient along their pathway. And if I go into medical secretaries' offices, consultants' offices, the members of our professional team, these are the sites that I've seen across my operational career, where we've got sticky notes, we've got patient labels sitting on a doctor's sleeve, we've got patient labels added to sheets of paper that people carry around, we've got the notes, we've got handwritten notes, we've got people putting multiple sticky notes because they've forgotten, and they've got different colour schemes for escalating those issues. And wouldn't it be fantastic if every office had the ability to see where a patient was, where they were in their journey, what next event they had to do themselves to progress that patient along the journey, and it be all auditable? And isn't that a much more stress-free situation to be in than having the cognitive load from the previous screen? So how do we do that? So today in the health service, we have multiple systems, multiple applications. We have patients staff who require to double key entry from one system to another. We heard that there's huge reluctance to change from teams because they have a confidence in the way that they've historically managed patients not to lose them. And we have had some fantastic analytical teams who have been able to produce reports, but it takes them a lot of time to produce those reports. And those reports, we end up arguing around whose number was right and whose number was wrong. And we have slight variation around those. So what do we then do? Oh, my screen's frozen. So we have these multiple systems. We develop and build custom connectors to allow track your PMS, to feed those systems that are feeding from those. And we have operational systems and operational people plugging in data into this complex system. And the larger the health service gets and the more targets that we get, the more people that we employ to run our data-driven system. And those individuals spend day after day inputting the same data, validating that data, sorting that data to the best of their ability. And there's massive cognitive load in the middle part of our organisation. Where I would really like us to get to is turning this triangle onto its head by providing a totally automated data management system so that we don't have to have individuals keying in and fixing the data. Less people doing the report production, less people involved in that sort of day-to-day administration and Groundhog Day, and more people driving the business change, ensuring the patients have the right elements of their journey managed, identifying where those patients could be sped through to deliver them their optimal outcome. So I believe that Insource has the answer to this, and that's why after 34 years in the National Health Service, I have chosen to end my career, hopefully with Insource. And what do? They take data out of multiple systems. So it's not system integration, which I've spent a lifetime trying to do. It's data, taking the same data out of different systems and presenting it, having done the quality check on it, through a decipher into the enterprise data framework and providing that unified data layer. And from that unified data layer, we can continue building and taking data from our acute systems, our community systems, our mental health systems, and we can link patient safety, we can link theatres and imaging, and gone are the days where we need 3 or 4 different screens open to understand where our patients are. We provide that through that unified data layer. And what does that unified data layer do? It allows us to stop using our data to report our failures and start using it to plan our successes. And a chief executive in England just quoted yesterday that having access to reliable data is changing the future. It's changing the way that we're delivering good quality outcomes to our patients. So, as I said, the financial, operational, other clinical and PAS systems are running. They don't change. Our day-to-day staff can continue to use those systems as they use them. We run that through our enterprise data framework and provide that unified data layer. And that gives us consistency across our systems. And what does that allow us to do? That allows us to layer applications onto that unified data layer. And those applications can be used locally, regionally, nationally, operationally. They can be used by the boards for performance management. And critically for me, they can be used to support our clinical teams in delivering safe and effective pathway management for any pathway, not just our cancer pathways. So that unified data layer can resolve all those data quality issues that we have, can support us through our Guru Planner to improve our waiting times targets and understand our capacity planning and understand the number of acute beds that we require to deliver what our planning teams ask us to deliver. It allows us to reduce that duplication of effort and the different answers that we all provide to the same question currently. And that will really start to help us provide the improved patient and staff experience. It provides some financial sustainability because we spend our money in the right places at the right time and spend it once. And it supports our national drive on that transformation agenda. And the Patient Pathway Plus cancer tracking solution supports the cancer strategy for Scotland. So I'll now hand over to Dennis and Charlotte, who will tell you how we've worked with Greater Glasgow and Clyde and how they're using the system.
Thank you very much, Donna. Just to introduce myself first, my name is Dennis Betts. I am the West of Scotland Regional eHealth Programme Manager. It is a position which is hosted in Greater Glasgow and Clyde, but I operate right across all of the West of Scotland boards, helping achieve a common goal, and where we're trying to collaborate and do something collectively. I'll pass over to Charlotte so that she can introduce herself as well.
Thank you, Dennis. Hi, everyone. I'm Charlotte Hilliard. I'm the Service Support Manager for Cancer Performance in NHS GGC. So we're just going to talk about the project and how it kind of came to be within GGC and kind of where we see this and really about what PP Plus brings to GGC, especially around data and actually having good and live data does for cancer performance. So Donna, next slide, please. Thank you. I've kind of had a quick kind of scroll through everyone here. So I can see most people are cancer performance management or out with. So I'll quickly brief over. So the 62 and 31 day targets, we know we have a 95% compliance that we should meet. Across Scotland, we're really struggling, everyone with the 62-day target. So that's having patients, for those who don't know, who are referred in and being treated for their cancer within 62 days. But we are generally meeting the 31-day compliance of 95%, which is when a patient chooses what treatment they have, they'll then get treated within 31 days. So we track those 10 cancer types that we're measured against. And we have monthly submissions to the Scottish Government as well as quarterly that we have to do. At the moment, the reason for the 62-day sort of challenge is high numbers of referrals, post-COVID, and also capacity issues as well in meeting these referrals. In terms of GGC, we have around 1,500 USOC referrals per week, which is at the moment outstripping our capacity to kind of meet those in that time frame. We also have 6 acute directorates. So GGC, because it is the biggest health board in Scotland, we're split. So we have sort of all these different sectors working together, and we have patients moving across sectors. So we have a patient might have a scope in the south, but then move to the diagnostic sector to have their MRI and kind of be responsible with them. And then they might move to the regional sector where oncology sits with the Beatson and then be treated there. So we have all these different service managers and admin managers involved in a patient pathway and then have their own reporting structures, their own financial structures. So there's quite a challenge there with kind of working together within GGC. We do it very well, but the data quality that we need to provide, we want to be able to, so we're quite competitive. We like to be able to measure it within ourselves and across sectors, which is quite difficult to pull those reports. We have a tracking team of 44 to manage that, to manage our 10 cancer types, as well as like NDT coordinators, a couple of them double up as. And then, as I said, we have these CSMs and GMs and admin managers from other services all involved trying to meet those targets. So Donna, next slide, please. So as majority of you will know, cancer tracking really needs to be proactive. As I said, the patient can move across all these services, like some of them in a single day. And it's about anticipating, okay, let's say if we need to bring this MRI forward to meet the target, what else do we need to bring forward, and having that whole picture and not just a snapshot. Particularly at the moment with our own reports sit in a different system to our cancer tracking. So we'll pull them on a Monday, and then let's say I have a meeting on a Friday. The report that I've pulled on a Monday is out of date. You know, it's even reflecting that the patient is on is on what day they are on Monday, but actually I'm talking about where they are on Friday, and they might have had those results reported, and that's not there. And a lot of our tracking is very narrative based rather than very succinct dates and reports. So same, we have multiple referral sources. So we have the bowel screening, we have the breast screening, cervical screening. We also have the A&E patients. We have patients coming in from other health boards, and also probably vice versa. You might get some from us as well through SLAs. And then also within cancer tracking, we have loads of ad hoc requests for data, like especially with breach analysis. I got an ad hoc request this week to look at all the patients within each sector for colorectal cancer by their surgery type, by their consultant, their consultant surgery, and the date of their POA over the past 6 months. And that's like, I'm on Wednesday and I've not even really made a dent in trying to get that information. So all these things that we really help with that data quality are actually quite hard to get for us. So next slide, please, Donna. So that is recognised in like the national strategy by the Scottish Government, that we need a responses system that efficiently supports this data collection, like the example I gave about this colorectal surgery data. So that can then improve service management, it can improve patient outcomes, and again can lead to evidence generation for policy development. And also we've been asked to provide timely, intelligent-led services. I'd say that the legacy system we had before PP Plus and Insource, it wasn't giving that timely, intelligent service. As I said, it was very reactive, and it was giving us information that was behind because we had to go into reports, and pulling reports was an effort. Cool. Dennis, this is your slide.
Thank you very much, Charlotte. So as Charlotte's already mentioned, obviously cancer tracking is not new to Glasgow or indeed anyone else in the entirety of NHS Scotland. But just so you can understand where we were operating from, is we had a very old legacy system which was used for cancer tracking in Glasgow. And to coin one of my favourite Scottish phrases, which I hear, it was very much on a sugarly peg and needed addressed. And back in 2022, we took that application and tried to update it as best as we could. So we managed to re-platform that and get the front end of the application running on Windows Server 2016 with a SQL Server 2019 backend database. So whilst that's all still fully supported technology, it was still very much time limited. It bought us time to do something more strategic and have a longer term vision for the future. And I suppose there were kind of a number of challenges which were confronting us there. First of all was the interface that we had from the TrackCare system, so our patient management system here in Glasgow, into the cancer waiting time system. That was written, I kid you probably not, decades ago, and the knowledge on how that thing hung together had walked out the door a long time ago, and it was really difficult to maintain. And we just couldn't make any changes to it for fear of breaking something. And obviously, given the statutory nature of all the reports that we have to produce back to Scottish Government, we really didn't want to tinker with that. The other big element which was constantly knocking on our door was the challenges of supporting the service requests for reporting. And as Charlotte has already alluded to, she is getting certainly weekly requests for various different slicing and dicing of data. So dashboards was very much being asked upon from our executive management to really understand at a high level how cancer performance was being managed and where the bottlenecks were. We were getting constantly new requests for either service or sector or hospital specific reports sliced and diced in a different way. And the reality is that whilst we could download the data from our existing legacy system, the amount of manual manipulation that was involved in giving those different slices and dices were incredibly time consuming. And the amount of effort and time and money that was just on manpower to service that need was just out of kilter with the back end benefit of that. Also, as Charlotte's alluded to, is a lot of the reports that we pulled, they're basically static snapshots. So they're only accurate at the time that the data is pulled. And this is a fast moving feast, particularly given the number of referrals which happen in Glasgow. often they are having to deal with data which is vastly out of, is significantly out of date already in conversations, and it just wasn't the right thing to be doing. So we took a decision in Glasgow, next slide, Donna, to change this. And well, just a quick snapshot of what our current system looked like is it's not the worst I've seen. I've certainly seen a lot worse than this, but you can see it's quite dated technology, and yeah, the usability of it was not always the best either. Next slide, please, Donna. So on that backdrop, we took a decision to look at a new system for cancer waiting times in Glasgow. And our first starting point in the project approach that we took is do a bit of an analysis to what other boards were doing. And through our conversations that we had, the one that grabbed our interest the most was the Patient Pathway Plus system, PP Plus, as used up in NHS Highland. And we managed to set up a demo of that system, jointly supported by NHS Highland and the supplier Insource. That certainly whetted our appetite, and ultimately we went into a procurement phase where we were able to purchase the Patient Pathway Plus system. And from there, we got in the room to really understand the processes, and Insource came into Glasgow to see how we currently operate. And they obviously had the knowledge of how the Highland system operated, and then got to see firsthand how it was all working in Glasgow to start the scoping, gap analysis, and ultimately the development that was needed to the existing product as used in Highland to meet NHS GGC specific needs. So there were a number of bells and whistles which got attached, but were seen as critical phase 1 developments for us in order to be able to go live. And to give a flavour of those, one was to be able to accept manual referrals created in TrackCare, because not everything was coming through as an automated referral. We also had to have TrackCare appointments interfaces, and when those appointments came through, is we needed to see them as a synchronal incremental chronology of an evolving event. So in Highland at the moment, these come through as individual events. So let's take, for example, a CT. So CT booked is one event, CT, the patient turning up is another one, then the actual CT being carried out is another one, and then the CT being reported is yet another one. We needed them as a single chronological event so we could see how these patients were progressing. Charlotte's also hinted in the structural setups within Glasgow, it being a very big board, needed to be catered for. So we have the concepts of sectors and specialties and hospitals, and how they all intersect with one another is incredibly complicated. There's quite a big mapping diagram which allows you to slice and dice the data as appropriate across sectors, specialties, or hospitals. And then finally, there were some additional data fields which needed to be put on for key data items that Glasgow needed to see in order to progress patients. Once all that development had been done, we went into a period of unit acceptance testing, UAT, to make sure that all those developments worked well. And then we went into a period of partial dual running. So this is where we took a handful of patients and managed them both in our legacy system and in the new system to make sure that they kept in sync with one another, to give us the final reassurance that everything was as it should be and could be taken forward. And only after we were satisfied that dual running was a success were we going to go into a full go live situation. Next slide, please, Donna. So to give you a rough timeline of how each of those key project phases took us, so the research was about 1.5 months, then the procurement took us about 1.5 months. The scoping and analysis and the development was our largest phase, taking 2.5 months, the testing just over a month, and then the partial dual running was scheduled for a month, but I think it slipped slightly after that. But that's a pretty quick timeline. And I'm delighted to say that we are now live as of the 27th of May. So we've been live for a few weeks now. And I think, you know, having been across projects and programs for a number of years, this is an incredibly ambitious timeline, particularly given the business change that we had to implement here. And I can only put it down to the huge testament to the collaboration that existed between NHS GGC eHealth staff, the service side that Charlotte's here representing, and also Insource. It's simply been fantastic, and it's been a real combined effort that we collectively all wanted to achieve this goal and being able to realize this really aggressive timeline and ensure a successful delivery of a project. Next slide, please. And I think I'm handing back over to Charlotte.
Yeah, so thank you, Dennis. So this is now what PP Plus looks like for us. So I've kind of popped out, this is a screenshot of what a patient's details are. So what's brilliant is we now have the trackers that can edit it and do the tracking that they need, but we have the service being on a read-only view, which will be further developed. So they can then go in and see the patient's details, and we have all these different sections. So we have the activity, we have an event section here, which is one of the tabs, and that's a fully auditable kind of feature within PP Plus, and that allows us to see who's been in, what kind of changes have been made, which is great for, if trackers are covering each other, but also it just provides us with that auditable layer of what actions are being done. We also have waiting time adjustments, which we can link to activities. And we also have a feature of ongoing wait time adjustments. So if a patient's in as an inpatient, we can add that. And then, then that gets filed into a separate report. Then the trackers can go back. So we don't have patients that we know are on medical suspension keep coming up in reports and kind of, as I like to say, putting a cat amongst the pigeon. We know we can't do anything with them at the moment. They are on a suspension, but they're up there and they're being alerted to government, when actually we do need to keep them alerted. But actually the patients that we really need to look at are the ones that don't have this wait time adjustment. We also have a way to kind of link patients to each other who, might have a lung cancer and a colorectal cancer. So the events are kind of linked together, which is great. Also great for wait time adjustments. And then kind of behind this patient detail is the report section. And it provides a list of every patient that's open in PP Plus. And as I've kind of mentioned, it's highly configurable. So if I want to find out how many patients are waiting on a scope, I can just kind of put that in and it creates that immediate report. And anytime I update a patient on their details, all the reports get automatically updated. So I'm always looking at, as long as my tracking's live, my report will be live as well, which is fantastic, and just so helpful. So that's what it looks like. And definitely I find it a lot easier to use as well. Yeah. Thank you, Donna. And yeah, so what does it deliver? So at the moment, definitely we're 3 weeks in to kind of go live, and it delivers that full patient event tracking along, so we can see all these different pinpoints, and it's very clear of what we have. Again, probably the most for me as in performance is the ad hoc reports that can be run in that kind of finer layer of detail, but equally it's what the services can do as well, because they have access to PP Plus. They don't have to rely on me to kind of ask all these questions. If they want to find out how many patients are currently waiting for an MRI that haven't been reported, or the report wait time was just over, they can then go do that themselves. They can have a look and they can sort of see their own bottlenecks and their own capacities. We can also look at how many downgrades, upgrades by consultant, and it's like immediately available to them. And again, we just don't have to wait for these monthly reports. It can be all put together. I said it interfaces with TrackCare, which is great. And again, it pulls in all our reports and it pulls in our inpatient procedures as well. So if a patient goes for a scope or goes for surgery, that's automatically pulled through. And yeah, rolled up the dashboard. And what's even better is it automatically creates the Scottish Government reports for us. So instead of that taking a couple of hours, that now takes us 1 click. And then obviously we'll validate the data before it goes off. But even that is just saving, from like 2 hours to 5 minutes. Just makes a world of difference in our busy jobs. And then a blended data model. So some things we have for manual, so we can add in different appointments, maybe that are out with board that aren't put in. And then we have the automatically pulled stuff from TrackCare as well. Thank you, Donna. Next slide. So the benefits of the new system. So for trackers, they've already said instantly updated and customized reports. They really like the audit log. And so far, the actual running of the system is quicker as well. So I kind of figured out, how long it takes a tracker to pull their tracking report is about 5.5 hours per week they spend doing that. In PP Plus, it is now 2 minutes. So we're releasing 5.5 hours of tracking of trackers' time to actually do the tracking rather than pulling a report that's like instantly out of date. So as I said, benefits for other team, it's really just making the data accessible to other teams and to the managers as well. And we have this feature within PP Plus, which is actions. So anytime we escalate that a patient might need to have an MRI forward, well, we can action that within PP Plus. The person that needs to bring it forwards get notified, and then that's recorded. All the escalations are recording against that patient. So we're actually seeing, are we making that dynamic tracking, and where can we make improvement for our escalations? And then the benefits for patient is that by being able to anticipate the next steps, having that live data, we can coordinate appointments, reduce multiple visits, and ultimately provide more timely diagnostics and treatment to meet those 31 and 62-day targets. Cool, next slide.
So just to bring it a bit real in some of the diagrams that Donna showed with you earlier on as to how this is set up. So here on the left-hand side, you can see the track care users which interact with the InterSystems track care system, constantly updating the patient details and the like. And that ultimately feeds then the track care database. We actually have a business intelligence mirror, which takes basically a more or less a real-time copy of the track care database, which can be done for reporting purposes. And it's that particular version of track care which then the Insource PP Plus system connects to, as to not to affect the live running of the track care patient management system. Through the various connections on the linking up track care to PP Plus, they use their enterprise data framework and ultimately all the rules engines that are built into it to identify the key data that they want to start displaying, because as you probably appreciate, there's a whole bunch of patient data in there, the vast majority of which we're not interested in. And it's through the rules engines that ultimately it's sifting through all the data to find the pieces of information that we are interested in, and then display that via this unified data layer. Now that we know which particular episodes we're sort of interested in, it then keeps asking for the updates to those particular ones and presents that in the front end of the cancer tracking solution. So that's where the cancer tracking team ultimately interact with it. Then there's kind of the report engine side of things that Charlotte has told you about, for like the national returns, but also then any of the key local reports which also need to be run. There is also the option to run our own internal additional reports on the data as well. So that is something we're considering for the future, because our executive management team typically get various dashboard reports for HR performance, ED performance, finance reports, and they obviously probably don't want to take themselves away into yet another system to see how cancer performance is doing. So we are looking at building our own MicroStrategy dashboard reports to service that particular community. And just to sort of say that these environments are duplicated right across the piece. So we've got 3 different environments. We've got development, a UAT environment, and ultimately a live environment, so that we can continue to do developments on the product and not affect the live running of the system. Next slide, please, Donna. So as I've already touched on, we have our eye on future stages, and where we would like to go with this is that we're looking at the possibility of doing further integrations to other systems, because as Donna's slides has showed you, you can connect to a whole bunch of different systems via the interfaces that exist. And we're looking at possibly interfacing to our radiology CRIS system, possibility to take chemotherapy data out of the ChemoCare system, and ARIA as well. What this system has also allowed us to do is open up much wider access to different clinical services. So at the moment, our legacy system is very much a closed shop, only being utilized by our cancer trackers. But because this is now a live database constantly being updated, and there are read-only permission views on this, it opens up the possibility of much wider clinical services starting to self-serve really on the data and cut and slice the data as they would like to see it. And the beauty of the system is that once you've got a particular view that you are interested in, is you can save that view and have the data constantly refreshed for your own purposes. Now that we've gone through dual running and we are live, we are getting some usability improvement feedback from the users, and so that's something that we'll take account of as well for the next phase of developments. And we're also looking to do much more automation so that it becomes a much more proactive rather than reactive system. So you could build in various rules like straight away action a particular group of users or an individual when certain events have or have not happened. So here's a good example of, well, give me anything that has the MRI due to report out with 7 days. And that give an alert for some proactive interaction from a team to start chasing those to try and ensure that the patients hit the various targets. At the moment, we're making use of an ODCB, a database connection, and our data is actually about sort of 12 hours behind the real-time track care system. And what we're looking to do is move to an HL7 real-time interface, so to make sure that the system is constantly updated with what is going on in the track care system. We were hoping to go to HL7 straight away, but that just wasn't possible due to the time constraints of the project implementation that we were looking to achieve. And also, as building out on all of this, that there has been talk of either regional or national platforms, given that this is something that's already been used by Highland, now Glasgow, and I know that there are a number of other health boards potentially interested in this, and it certainly opens up a conversation of actual regional or national platform instances. Next slide, please, Donna. And with that in mind is really you could do this a number of different ways, but here's just one idea where you could still have your own individual instances running, but ultimately have a consolidated cancer unified data layer to really give you the cancer performance right across Scotland or in a region, depending on how that might be sliced and diced, to start giving you consolidated waiting list views and give you much more drill down into regional performance and really help with the capacity and demand planning. And that could really help you then reshape services and help deliver things where capacity and demand flows exist. Next slide, Donna, please. So in summary, what I hope myself and Charlotte have been able to do for you today is build on what Donna's showed you about the greater product of what Insource have, but bring it to life for a real case instance. And I can absolutely promise you we are now using this in anger in a live environment, and it has really been well received. And I think that's really because we've been able to move to a much more flexible and automated and constantly updated system that was just not possible with our old legacy system. I think it's fair to say that where we are at the moment is it's really about evolution, not revolution, but we are certainly wanting to really move into that revolution space, and we have quite a wish list for our phase 2 developments to really change the way that cancer services and cancer tracking is managed here in Glasgow. But at the moment, it was really about replacing an old legacy system, and therefore it was really about kind of like for like type functionality. But we have been able to make improvements, as we've hinted on throughout the presentation. And ultimately, I suppose, as to summarize it, is that we're really hopeful for the future because we're really starting to see the significant harnessing of the power of the data here and what it is starting to show us, just something which was too clunky with our old system. And ultimately, what we have as a key outcome is to try and deliver better clinical outcomes for our patients and their wider loved ones, because cancer is something that affects the entire family. I think that's our last slide, hopefully. I can't remember. Donna, I don't know if you've got a questions one, but thank you very much for listening, and I'll now pass back on to Nadine. Thank you.
Thank you, Dennis. Thank you, Charlotte and Donna, as well, for your presentation. We've got a number of questions that have come in so far, but please, if anybody's got any questions, please pop them in the chat and we will try and answer them. First of all, I'll answer one of the questions that came in, and that was a question around we don't use track care and we're still using Topaz with no plans to change. Would that be an issue for implementing Patient Pathway Plus? No, absolutely not. Obviously, we've been operating in England for a couple of decades now, and it is the norm in England that different trusts have different systems, different PAS systems, different EPR systems, and we have a number of customers who are at ICS level. Each of the trusts within the ICS have a different system, so it's not an issue at all. We're used to bringing data in from lots of different systems. What it does mean, of course, is you have the same visibility, you have the same reporting ability as all the other health boards, so it doesn't make it really doesn't matter if the data is coming from a different system. Right, some of the other questions that we've got. So how does the system know which activities in track care are linked to cancer pathways? Would anybody like to answer that? Charlotte? Dennis, you've got your hand up first.
Yeah, I can take it, and then Charlotte can add. So basically, all of the referrals initially come in as a USOC referral, urgent suspicion of cancer. So that is ultimately the key flag that we are looking for. And associated with that is any track UCPN. Now, it's a unique number. I'm not sure what the acronym immediately stands for. Maybe Charlotte might know, but ultimately all activity then hangs off that unique UCPN. So once we've got the UCPN, we start looking for any associated activity with that UCPN and keep bringing it in and updating the record. But how records first come in is that we look for any new records which have got an urgent suspicion of cancer flag against them. And there's other slight data rules that we do to refine on that, because it's only specific ones that we have to track. But that's the key one that we flag on, and then ultimately bring in the activity data associated with it as the patient progresses through the pathway. I don't know if Charlotte, anything further to that?
Yeah, UCPN is unique care pathway number, but yes, it pulls from that, and so it pulls there. But also, what's great is so it'll keep pulling from the UCPN, but it also pulls through from that initial referral, the vetting and the referral kind of priority. So which is great because we've built PP Plus already has an inbuilt rule that, you know, if it's come in as a USOC or it's downgraded, like it still pulls through, but it marks it as a downgrade. And then obviously as a tracking team, we'd make sure that there's a letter that's been gone back to the patient and the referrer. So we can then keep a track of our downgrades or upgrades, which is fantastic. And it also pulls through if a patient hasn't come in as a USOC but then gets upgraded to a USOC, it automatically puts that into the correct pathway that it should be into the 31. And so then that's all done. So then the tracker doesn't have to do that extra step. And when they just check it all as they do as part of the referring bit, it just makes the few steps a bit quicker. So yeah, it links everything through UCPN and track. And that's the same with the inpatient waiting list. So it's able to pull, even though they're like separate identities, like appointments, and we have inpatients, it can still pull through, which just saves a lot of time for our trackers.
Okay, thank you, Charlotte. Another question, can it produce reports for pathway analysis for breach patients, as well as patients who meet target and those discharged with no cancer diagnosis? Charlotte?
Yeah, so I'm working with Insource at the moment to have breached analysis reports as like a separate, so at the moment we would just look at the patient and create our own report, but we're looking to have that built in, and then, you know, kind of have the built-in actions of pathway completed, this is breached, and then create an action to all the services the patient went into. So that's something we're working towards in phase 2. And then reports for those who do meet target, it automatically creates that. So I could go in just now and have a look at my system and it would tell me exactly what my current performance is, just based on what's been done. So you know, I can kind of look now, but I can also have that forecast of where I might be. And then those with no cancer, when the trackers put like closed patient confirmed not cancer, what you have is then you're able to put a report in. You can create your own view of patients not cancer by month, by cancer type, and then you can have easy access to your conversion rate as well. And then again, you have the referral details all there, so you can say, well, how many weren't cancer, but was it an appropriate vetting? And you have all these different kind of pathways that you can go down because this data is so readily available.
Okay, thank you, Charlotte. Another question, I think maybe partially answered already, but does it pull MRI CT data from RIS? And if so, how does it know that the scan is linked to a cancer pathway? Anybody like to answer that? Dennis?
I'll kick us off. So at the moment, we have not interfaced with any other systems other than Track Care, and the only data we're pulling in that kind of space at the moment is appointment data. As I put up on my slide of phase 2, we are looking to enrich all of that to hook into our order comms functionality, which sits within Track Care, so that ultimately we can better track when various tests, procedures, investigations have all been requested, patient attended, and then reported on. Ultimately, if we actually need to go to the systems like RIS or MRI or CT, whatever the various systems that hold that information to actually pull the specific scan or the specific report, that is something which is on our radar, but only really as that particular line and something we may want to look at. We have not yet investigated that and how complex that would be, but certainly the kind of order comm side of things where we can track that patient pathway more is certainly definitely on our radar. Don't know, Charlotte, if you want to add anything further to that.
No, I think it's that. Yeah, I think it's probably one of our next top 5 priorities, just because of the amount of work that can go into the imaging, and we have pathology trackers that we include as part of our cancer tracking. So it's about making all that slicker, and so I think that's one of our top priorities as well, is just to have that implementation.
Okay, so another question, I'm not taking these in any particular order. Are MDT proformas incorporated into the patient record in PP+? Donna, do you want to answer this?
Can you repeat the question? Are MDT
proformas incorporated into the patient record in PP+?
So the PP Plus product isn't the definitive patient record. It's a pathway management tracking solution. So when I was in Glasgow, was it just last week, Charlotte? It was. We've started to have discussions with the MDT proforma developer in Greater Glasgow and Clyde, with the MDT teams, and have identified some opportunities which may or may not come into scope in phase 2. We need to continue those discussions with Greater Glasgow and Clyde. But absolutely, we're not the definitive source for the cancer patient record. That's not what the tool is about. So I think Charlotte would be able to say where the MDT proforma comes into the record in Glasgow, not me.
Yeah, so from the MDT, we just take the outcomes of the actions. So really what we would kind of be looking with PP Plus is to sort of just automate that action summary box, which is in the form of the MDT, and then just put that in a quicker way. But at the moment, just they'll add in as an event, patient went to MDT, and then they'll type, which is the same as what they were doing on the legacy system that we have. But yes, we're looking forward to how can we just pull the actions that are needed, and again, just making MDTs a bit slicker, so and the forms more interactive from there.
Okay, we have some more questions, but we also have a couple of comments. So Gary at NHS Shetland has said, obviously it would appear that Shetland do things slightly differently, and we know that every health board has different operating procedures and does things differently. So Gary has said we don't have order comms yet, all appointment data is in RIS. Also mentioned that UCPN codes are not used well in Shetland. That really doesn't matter. We can bring the data from whichever system you're using and capturing that information. It is a highly configurable system, but it doesn't matter if you've got that information during the implementation process. And this is why we would do a scoping exercise with each of the boards. We want to understand where your data is, and if that isn't in TrackCare, it's fine, it may be somewhere else. During the scoping, we say, okay, what data do you need and where is it in your systems? And that's the point of the scoping, so that we agree between us where that data is, what data you require, and because you might want to use this slightly differently than some of the other boards, and we would work with you to bring the information that you require into the patient cancer patient tracking solution. But absolutely, regardless of where you've got that data, we can help you bring it in, as long as it is in a data format, as long as it's not, you know, on a piece of paper somewhere, we can help you bring that in. So that was less a question and more of a point. Donna, you've got your hand up there.
Yeah, I don't know if there's anybody on the call from NHS. Well, I know there's people on the call from NHS Highland, but I don't know if there's any specific data people on. But and I'm hopefully not speaking out of turn, but when I was in NHS Highland 12 weeks ago, UCPNs were not reliably used across our system, and we had a lot of duplicate UCPNs raised for individual patients, and we had historical data quality issues around our UCPNs. So we know that there's solutions around how we identify those pathway numbers, and I'm sure Dennis or Charlotte would come in and talk about some of the functionality that developed from the Highland solution to the Glasgow solution around those additions of manual referrals generating a UCPN and how we link those UCPNs, if that would be useful to hear, Gary.
So I think we've actually come to the end of the webinar. What I would suggest is, it looks like people are dropping off because we've come to the end. I think if we continue and just answer some of these questions, and then we can make this available to anybody who wants to access the questions at the end. So I'm not sure if Gary is still on, but if he isn't, we will obviously send you this recording so that you can hopefully get the answer to that question. I'll just quickly, I know we're over time now, but I'll just quickly answer a couple of other questions that we've got. So another question is, have you seen an improvement in achieving the 62-day target since you implemented the system? Charlotte, do you want to go for that one?
We implemented it on the 27th of May,
Yeah.
so we've actually not got a report of that yet, but to be posted around when the June data comes out, we'll be able to report on that. But I know definitely Donna had that experience, that she's got like a good example from when in NHS Highland with like urology improvement from that. So I'll float back to Donna around that performance, but can't quite confirm yet with Glasgow.
Okay, thank you, Donna.
So yeah, absolutely. What Glasgow have committed to do with ourselves is to do a case study around the benefits as we implement the solution in Glasgow. For Highland, when we implemented the solution for urology, and we used the tool actively at weekly meetings with our urology nurse specialist, for example, to track his patients, what we saw was that NHS Highland moved from the worst performing urology pathway performer in Scotland, and they have sustained being the best performer. Now, that doesn't mean that they're always achieving their 62-day and 31-day target in urology, but what we have seen is a sustained improvement in that performance. The aim for Highland is to developed that way of working with all of their pathways, including the low volume pathways, which we all recognise that low volume pathways are very difficult to put the whole cancer tracking tool mechanism behind, whereas this solution identifies those low volume pathways simply and quickly.
Okay, thank you, Donna. And we have another question here, and this is a valid question about how all the boards, although they might be on the same solution, they may use the same solution, might actually have different operating procedures and do things slightly differently. But maybe, Donna, you can answer this one. So have Greater, or Charlotte indeed, have Greater Glasgow Clyde found that it takes longer to track individual patients in Pathway Plus compared to your legacy system? Because Highland felt it increased tracking time per patient, but felt the benefits from reporting outweighed this.
Do you want me to go first on that one, Nadine, and then Charlotte
Okay.
can follow in? So absolutely, there's trade-offs alongside anything that we do. And what we're in early discussions with Highland with is looking at taking on the solution that Glasgow's developed. So I think some of the solutions that Glasgow have developed within the product have sped up cancer tracking, which if Highland then adopt, they then get the benefits of the significant benefits of reporting, and that you then start using the tool to its maximum efficacy, which should speed up the cancer tracking for the individual cancer tracking teams.
Charlotte, did you want to come in on that one?
Yeah, definitely. As we've we're week 3 into this now of using the new system, and a lot of the trackers were then we had a month and a half or a month of dual running before that where we were matching patients. But definitely the trackers are very self-aware that it is taking them a bit longer to be on patients, and that's just because they're finding sort of where things are and it's all brand new. So they're very conscious about how many clicks things take. But overall, the time it takes for them to run their reports, they're completely satisfied that has improved it. And as they just get better literacy with how to use the system, it will improve, and they all have acknowledged that as well. So it's just a bit of, it does take time to get used to the system. I kind of had a bit of a slow moment today with it of trying to find things, but it's all just learning. And I think if you factor that in, if you do have this sort of system changes, if you factor that in and you kind of make the staff very self-aware that they are going to be supported during that, and we're very aware that tracking might slip a bit as people kind of figure out where the new system is, but we're here to support them. And I've been on the system since March, so I'm very much kind of one eye on what we've been doing and kind of helping people where they might make an error, and we've been validating all our data, and we'll go through it really with a fine-tooth comb, which will be made a lot easier with the new system for the submission. So I think it is kind of definitely in my term, I probably spent, and Donna was here last week, just kind of watching me do my reports. From a management side, I think I spent about probably 5 hours overall over the course of 2 days just manually manipulating a report, when actually I could probably be spending that time looking at my pathway, looking at demand and capacity, kind of making those QI improvements, rather than manually manipulating a data. It's not best use of my time, and probably my manager thinks exactly the same. So yeah, it's about kind of the benefits you have from the top level, but also the kind of speed you have at the bottom.
Okay, thanks, Charlotte, for that. We've actually answered all of the questions that came in today, but what I would just like to add is that as we get more health boards using the system, we appreciate that different boards work in different ways, and we would really benefit from input from other health boards on how they operate and their requirements. And I think Dennis mentioned that we're about to move into phase 2 at Glasgow, because we were very time constrained on phase 1 and what we had to deliver very quickly. But that gave a kind of wish list of, oh, it would be great if we could do this. But what we want to do is we want to get opinions and ideas from other health boards as well, and we would really like you to feed into the future roadmap of this product, because we do appreciate that people do things differently and have different ideas, and also then that allows you to learn off each other how you're doing things differently, how improvements might be made. So we'd really appreciate your input. We will shortly be organising a user group that we would ask other boards to attend, even if you're not currently using the product. We would like you to, we would value your input into it, and, you know, ideas around reporting. Obviously, you can all share things, share reports, anything that developed in the system will be shared across everybody else. A question has just come in, is this product available on a national framework? Greater Glasgow and Clyde purchased this through G-Cloud. They did a direct award. Greater Glasgow and Clyde, their purchasing department, James, who worked on the purchasing side, did an absolutely fantastic job, and he has said that he will share all of the paperwork that he produced so that you could go down the same path very easily. So yes, there's absolutely a blueprint for how you could procure this and how you could procure it quickly if you wanted to. When will the Glasgow report be ready to be shared? I'm not sure what report that is.
I'm assuming, Serena, that that's the case study report. So I think we've got a draft outline of what we're measuring. And it was lovely to hear Charlotte talking about 5.5 hours per week per tracker saved in terms of producing the reports. So we understand those baseline measures that we've set out as a measure of success for the first implementation period, but we need to ensure that the system's been live long enough for us to understand any improvements and those time delays. We've currently got a report running on a user satisfaction survey, and I was looking at some of the results that have come in from that so far. So to answer your question, Serena, probably we're 2 months away from producing our first case study, just to give us because we're coming into the summer months as well. So we've got to, I would hate to overpromise and underdeliver. I don't know, Dennis, Charlotte, do you think 2 months for our first case study is realistic?
There or thereabouts,
Yeah.
give or take a month. And I think it's also worth to say that this isn't a one-stop visit. We were going to come back throughout, I think we were saying 3, 6, 9, 12 months or thereabouts as well, again, to see how this is improving, because yeah, as we've touched on, implementation of any new system is probably going to give you a dip in performance just because people get used to the new system, and it's when people get used to the new system on all its bells and whistles and functionality, that's when you can really start seeing the improvements. So we're not just doing it as a one-stop shop, we are looking to track this over a longer period.
And I think if there is any documentation or any support that anybody needs, there is a business case available that has been written. So if you're looking to create a business case for your board, we appreciate the difficulties in trying to source funding for this. So if we can help you anyway, if you'd like a copy of the business case, please just drop us a line and we will absolutely send that over to you and try and support you in any way you can. Glasgow, as I've said, have agreed to share any paperwork that they've got, anything around procurement, please reach out. I know that both Charlotte and Dennis have been absolutely excellent in contacts from other boards. Charlotte and Dennis, I'm sure, I know I'm speaking on your behalf, but I'm sure you would answer any questions from any individuals that want to contact you directly and have a chat with you.
Yeah, far away. You can grab my email from, I think if you just hover my name, but it's also on the slides, so just, yeah, go for it.
Okay, so before we just wrap up, has anybody else got anything they'd like to add? Any of our presenters, anything else they'd like to say before we close? Okay, thank you very much, everybody. It's been great having you and seeing your questions today. We will make this we'll make this presentation available because we did record the session. So if you'd like a copy, I know some people joined later on. They may have missed the first half, for instance. So please get in contact and we will send a copy over to you. Anything else, please, we're here to support you. If you want anything else, please just ask and we'll do everything that we can. And hopefully we'll be speaking to you very soon about coming implementing at your health board. Thanks very much, everybody.